The following podcast is part of a certified educational activity titled Remembering Brain Health, Targeting Modifiable Risk Factors and Early Detection of Cognitive Symptoms to Reduce the Burden of Dementia. Access the entire activity and complete the post-test at peerview.com/UAH860. Downloadable slides and practice aids are also available.
Okay, good afternoon and welcome. Welcome to our session today on remembering brain health, targeting modifiable risk factors and early detection cognitive symptoms to reduce the burden of dementia. So today's panelists are my colleagues that you see up here, Dr. Scott Kaiser and Dr. Barack Gaster. So I'm going to start us off. So one thing that we know is Alzheimer's disease is a growing public health challenge. The number of people who are currently living with Alzheimer's disease is estimated at about 7 million individuals, and this number is growing. We anticipate that this number will grow to 14 million people by the year of 2060. Early warning signs are frequently missed. So some of the CDC data shows that about 10% of people aged 45 and older report subjective cognitive decline. What subjective cognitive decline is they say, in the past year, my memory and my thinking has gotten worse. So these are people who are recognizing that their memory is changing. And we also, a next point we want to keep in mind here is that 99% of clinicians are underdiagnosing MCI. So we have people who are recognizing that their memory is getting worse, but they're not necessarily being diagnosed. And so one of the things that we want to think about is why? Why are they not being diagnosed? And we know also from CDC data that many, if not most, almost 50% of people who say, my memory has gotten worse in the past year, have actually spoken to their healthcare provider about that. Why does that happen? There's a variety of reasons why that could be happening. It can be the stigma. It can be time constraints. It can be barriers. And so we're going to learn today from our experts up here what we can do as providers to help reduce some of that and hopefully get patients more comfortable having that conversation. The other thing that I want to point out to you today is when we look at the trajectory of Alzheimer's disease and related dementias, there are opportunities for intervention or prevention at each stage of the disease process. So what this slide is showing us is, I come from a public health background, so we would talk about this first row of people as being primary prevention. This is the risk reduction. This is engaging in those behaviors of doing things early to try to delay or maybe prevent the occurrence of the disease process. Secondary prevention, or that next line, is that early detection and diagnosis. So getting people in, getting them worked up, getting the disease detected and diagnosed if there is something to detect, that in itself is an opportunity for additional types of interventions that can move forward. Tertiary prevention, or this care, so once somebody is diagnosed, thinking about that care coordination and doing things to maximize their quality of life. That is the tertiary prevention. So GSA has developed a toolkit that really provides a structured approach for improving early detection and management of cognitive impairment. This toolkit is free and available to the public. And you can find it at carebrain.org. And so at GSA, CARE is spelled KAER. So each of those letters, yes, we can spell it GSA. Each of those letters stands for a step in the process. So K is kickstart. Kickstart that conversation about brain health. A is assess for cognitive impairment. E is evaluate for dementia, and R is refer to community services or out to additional specialists. So Dr. Gaster and Scott, Dr.
Kaiser.
Dr. Kaiser, we get calling each other first names, and then, each of their presentations are going to be focused on specific letters of this framework. So once again, this is a free downloadable resource, and so many of the tools that they're going to talk about can also be available at carebrain.org. Now, brain health. This is a term that we use, a lot of us use in this space. What does it really mean? And the thing that we need to think about is brain health is more than just the absence of disease. Brain health includes so many aspects. I mean, includes the various risk factors of the things that we do to keep our brains healthy, many of those good ones, such as the protective factors. But this is a whole life course perspective, and it's a continuum. So your brain health can be really, really, really healthy, or it may not be as healthy. And it is also subjective. Everybody has a perception of not just their physical health, but their brain health. And then there are also objective measures that we can measure it as well, and it's multidimensional. And so you can see some little more details here, but the key that I want you to think about is brain health is not about an absence of disease. It is a continuum. The other thing that I want us to think about today is when we're talking about brain health and we're talking about the care framework and the process of the disease trajectory, it involves not just one specialty. It involves many different specialties. GSA has 26 different disciplines represented in our organization. And my guess is in this room, we probably have almost those 26 different disciplines represented. But I want you to think about, you may be sitting here thinking, this is a great lunch, but I'm not sure how this is going to be relevant to my life. Think about your specialty and where you fit in this category, and whether you are a physician, whether you're a pharmacist, behavioral scientist, case manager, care navigator, nursing background, you have a role in this trajectory. So our goals today's workshop is we're going to talk about adopting healthy brain habits and addressing modifiable risk factors that can help delay cognitive decline. Second, we're going to talk about some of the validated cognitive assessments tools that can be used to identify early changes and help differentiate mild cognitive impairment from normal aging. I'm sure you've all had that conversation. People say, I sometimes forget my keys. But people want to know, how do you distinguish between what normal cognitive decline is and ones that you might want to talk with your healthcare provider? You're going to hear a little bit about that today. Third, we're going to talk about effective communication and collaboration among clinicians, patients, and care partners, and how critical that is to promoting brain health and facilitating early recognition of those cognitive changes. All right, I'm going to turn it over to my colleague, Dr. Scott Kaiser.
Thank you, Dr. McGuire. So I'm so glad that you mentioned prevention so many times in the opening, and it's really wonderful that we're having a moment where so many people are talking about and thinking about prevention in terms of prevention of dementia, brain health. And it's interesting, actually, when we published this paper cited here, there was a lot of debate around, use of language of risk factor reduction versus prevention. And I think we can recognize now that there are, as we said, there's a life course issue, and there are opportunities for prevention at every point along the way, whether it's primary, secondary, or tertiary. And as a geriatrician, this is something that I think about a lot and share a lot, and I'm sure many of you think about, that it's never too early, right? We should all be doing, I'm actually been watching what everybody's been eating. I've been watching to see who's been socializing and who's been isolating, right? Never too early and never too late, right? When I was doing my fellowship here in Boston, I remember people were doing this amazing study where they had centenarians doing weightlifting and leg presses, and then they did the cross-sectional MRI, and they could see that even though with age, yes, we tend to have more fat to muscle ratio, that there's an increase in the fat content there, but that with those leg presses, even the 100-plus-year-olds could bulk up their muscle and flip that ratio. So again, never too early, never too late. This is really a life course issue. And it's exciting, too, that we have a growing body of evidence supporting this approach, and we know that there are a multitude of modifiable risk factors that we can be targeting. So one sort of cornerstone here would be the Sprint Mind trial, which demonstrated that targeting modifiable vascular risk factors has an impact. So you had folks that were treated for hypertension to a target goal of less than 120 as opposed to less than 140. And sure enough, the relative risk of developing mild cognitive impairment was significantly reduced. Now, in this study, it did not show a statistically significant reduction in dementia risk, but first of all, in the composite group of MCI and dementia, there was a reduction. And two, you have to take into consideration that the study was stopped early because of its clear efficacy and the low number of cases. So that's sort of a caveat, but if you look at it on its face, no question, we should be treating to a tighter target blood pressure for reducing the risk of mild cognitive impairment. And again, the big picture thing is saying, hey, target these modifiable risk factors. And we're going to talk today about what's good for your heart is good for your brain, right? So now taking this a step further into the kinds of things we can do about it, there was the finger trial in Finland that showed that if you gave people information and you put them through multimodal lifestyle interventions, that this would be effective in people who were not cognitively impaired but were at high risk, showed that you could reduce that risk. This was a big deal. So now we've had an effort to replicate these studies globally, and we just got the top-line results of the U.S. Pointer trial at the recent International Alzheimer's Conference, and sure enough, these lifestyle interventions were effective in reducing the risk of cognitive decline in older adults. So again, there are things we know we can do. And I'll take that a step further. This was broken into two arms where there was a self-guided or a structured. Both were effective, but the structured had more benefit. So people need our support. They need structure. They need guidance. They need programs. And we need to develop these types of programs that we know will work. So let's talk about targeting modifiable risk factors. And let's break it down into a simple framework, starting with our ABCs. Active lifestyle, balanced diet, chronic disease prevention and management. Again, things we can be doing across the lifespan. And coming back to that idea of imagine if we could cut that number, right? The 14 million or the 150 million people globally predicted by 2050 who will be living with dementia. Imagine if we could cut that number nearly by half, right? 45%. And that's exactly what experts tell us in the Lancet Commission consensus guidelines, that if we addressed all of these risk factors across the life course, we could reduce rates by something in the order of 45%. I mean, that's really striking. And then look at these and think about how your work might touch one of these areas, many of these areas. Think about the opportunities in a direct clinical relationship. Think about the opportunities from an advocacy perspective. Think about the opportunities from a public health perspective. That if we address everything from air pollution to whether or not individuals smoke, all of these factors here, how active people are, whether they're drinking or not, quality of education. Again, broken down in terms of early life, I go back even to prenatal care, midlife, and late life, opportunities across the life course that we can have a significant difference. People seem to get caught up on the power of the risk factors like genetics. Sex is unfortunately a risk factor. If you're female, you have an increased risk. You can't change those things, but age is a risk factor. Our age is going to keep going up, and we know that's okay. We just want to keep going up as well as we can. Let's not focus on those things that we can't change. Let's focus on all these modifiable risk factors, which this is a list, I'll add, that is increasing, right? This is a list that they keep adding to as they review the literature. So clinically, it's very important that we're assessing these modifiable risk factors. And a lot of this, thankfully, fits into routine care already. We just need to, one, be a little bit more explicit about it and more consistent. And that's what I think we're going to be hearing a lot too from Dr. Gaster and this care framework, care toolkit is, for example, making sure that there's consistent and appropriate assessment of cognition and screening for memory problems. We're really not doing a good enough job of that. We've got to find ways to be able to detect cognitive changes earlier. And again, thinking about these things, cholesterol, blood pressure, glucose, the things that are bread and butter of primary care, and formulating it within a brain health perspective. And then adding to that we also have to consider sensory, social, and functional well-being. Things that, again, that all too often get overlooked. And again, going back to what's good for your heart is good for your brain, we can borrow from the American Heart Association and look at their 8 key measures for improving and maintaining cardiovascular health. And do these things translate to brain health? Of course. Of course. Eating a brain healthy diet, whether it's Mediterranean mind diet or some related diet, being physically active, managing blood sugar, weight, and blood pressure and cholesterol appropriately, getting people to quit smoking, obviously, and healthy sleep. This one is just such a major one that, again, just because so many of my patients suffer from sleep issues and so many of my patients suffer from undetected, undiagnosed sleep apnea. And it's amazing. We catch the sleep apnea and we treat it, and it's just their whole life can turn around. It's really, that's a very satisfying thing, by the way, to be able to help people in that way. Okay, so now the care, the real care, however it's spelled. Let's start with K for Kaiser. Kickstarting the brain health conversation. Okay? And this is big, actually. A lot of this stuff seems so intuitive, and it is, but it's not common practice. And the way we set the tone about brain health has all the difference in the world. And think about it, where we're coming from. People are so used to really either their concerns just being dismissed, 1, it not being mentioned at all, 2, being totally dismissed, or 3, the fear mongering, the fear factor, right? The just like the sky is falling, the nihilistic, there's nothing we can do about it. And as we've been talking about, don't ever think there's nothing we can do about it. Nothing could be further from the truth. There's so much we can, should, and must do at every stage, like we said. So meaningful conversations about brain health, they begin with trust. That's why I love that we're going to hear so much about integration into primary care, where there's already a trusted relationship. That's so valuable. It's about establishing rapport and having genuine concern, communicating with each patient as an individual, knowing that there are cultural variations, individual variations. I mean, I've had some patients who just, without even, before we start the conversation, just immediately say, if I'm ever like that, end me now, right? And then it's a whole spectrum, but you've got to gauge it and you've got to personalize it. So this is really about good open communication, right? Good nonverbal communication, good verbal communication. I probably overdo the we. I'm always, because I'm sitting there thinking about my own brain health too and my own risk factors. So I'm like, hey, we better eat a healthy diet. We should cut down on alcohol, whatever it may be, right? I mean, I think that we and us, that we're in it together, because we're all trying to improve our brain health and we're all trying to reduce our risk. And then I think, again, making sure that the environment, this is not stuff where you want to just run in like, oh, I was at a seminar and now I know I need to kickstart the conversation and bull in the china shop. This is sensitive stuff, and you want the environment to be appropriate. You want to make sure, even if you're rushed, that you at least give it the credence of the fact that we'll make time for this, even if you have to schedule a follow-up visit, right? You really want to create the right setting, and it's personal and private, and there's stigma and there's ramifications of these things, right? So you want to ensure privacy and to be a appropriate environment, and you need to be culturally attuned and culturally directed, because you can't just make broad assumptions. There's various different cultural perspectives on changes in brain health. So what are some key messages? Well, the brain ages just like any other part of the body. And this is a big one for me because it's like, gosh, we do all this about blood pressure, we do all this about cardiovascular health, and then, oh my gosh, if it comes about the brain, we kind of go as if it's a whole different, not attached to the body. Of course, it's part of our whole health perspective. And of course, the brain is aging, and we need to, as a geriatrician, I'm not going to neglect your brain. And as you know, I love this one. We can take steps to protect our brains and prevent cognitive decline. I want everybody I meet to know that there are things we can do to protect ourselves. So what's good for the heart is good for the brain. There are now treatments for cognitive decline and Alzheimer's disease. We get to have a discussion about things. There's a great handout on your tables from Bright Focus Foundation that has actually talks about all of the different FDA-approved treatments in terms of things that are targeting amyloid versus treating symptoms, etc. And cognitive aging is different for everyone. We don't assume, we don't make broad assumptions. What we like to do is we like to actually see how you're doing, see what's important to you, and then evaluate your cognition using standardized, validated tools, and then begin a conversation. Understanding there is heterogeneity. We don't just assume, oh, that's normal aging, or oh, that's pathologic, or I should want this. No, we have to target it. And cognitive aging in and of itself is not a disease. And I know many of you in this room know that. It's a natural lifelong process that occurs for everyone. And I think those, GSA members who've published things on how the brain, how cognitive function actually improves and becomes more refined with age, right? There are changes, but sure, does processing speed go down? Yes, typically. And will that have impacts? Are there other parts of cognition that change in both directions? Of course. That's natural. So there are simple tools that can support effective brain health conversations with patients and families. So here's another cool thing you can download, this patient education practice aid. Again, simple handouts, great. That way people can have something to look at ahead of time, to take home, something to kind of really put the focus back on. And I like, again, incorporating this. This doesn't mean if I hand you this handout that you've got a problem. I hand everybody the handout because it's important for all of us. This is routine. And this should be incorporated into any relevant visit then. And you can have posters, again, just so that this is as important, just like we would talk about subsets of this, like quitting smoking, important for everybody. Okay, so let's talk about preserving brain health in older adults. So I talked about frailty. Very important to understand this frailty phenotype, this frailty dementia risk progression. Frailty independently predicts dementia and has a critical role in transition from MCI to dementia and within dementia progression. So think back to my first graphic, right? And think about that importance of that connection between frailty in terms of the risk of developing MCI, in terms of the risk of progressing to dementia, and then the risk of the progression of the dementia. So really important that we recognize and intercede at any point there. And we can use validated tools and then interventions to modify this, right? Things like, as I mentioned earlier, the resistance exercise, right? Never too early, never too late. And then we need to address overlapping contributors like malnutrition, polypharmacy, inactivity, etc. And then coming back to the hearing testing that I talked about, and we didn't talk about vision yet, sensory health is brain health, right? We have to ask about sensory changes and functional impacts that they may be having during our visits, and then coordinate with audiology or optometry for evaluation and assistive device fitting. We want to encourage the use of hearing aids and vision correction to improve communication engagement. Again, that's where I focus a lot with my patients on trying to just kill that stigma thing and say, hey, this is like a really key positive step. This isn't labeling you in a negative way. This is you being proactive about keeping your brain healthy and reducing your long-term risk. And then linking people to affordable hearing and vision resources. And then, as I said, something that I spend a lot of time thinking about, assessing for and mitigating social isolation and loneliness. We know that social isolation and loneliness are common among people with dementia and their care partners. We know that social isolation and loneliness increase our risk of cognitive decline. And we know that there's a common clustering of social isolation and loneliness with things like with chronic pain, fatigue, and depression. So it really can be this sort of linchpin or foundational element that we have to address. And I call it a connection first approach. You've really got to focus on creating connection before, otherwise you get this nasty cascade of all these other risks and comorbidities that stack on it. And this is an opportunity where tapping into that village, it takes a village of multidisciplinary, tapping into community-based organization relationships, so much opportunity to create connection through a rich network of connection and a well-connected team. And then thinking about social prescribing as an opportunity to mitigate these risks, right? Through referrals to senior centers, exercise programs, volunteer programs, arts programs, friendly call programs, intergenerational programs, etc. And I will note that, again, I'm very excited about social call, friendly call programs. There evidence, randomized controlled trial evidence showing that empathic phone calls from trained lay people have been proven effective in reducing loneliness, depression, and anxiety among socially isolated older adults. So this works. We should be on the lookout. We can use the tools. We could have a whole different seminar about which screening tools we should or shouldn't use, but just use something and ask about it and talk about it and do something about it. And then along those lines, medications impacting risk of cognitive impairment is such a huge thing. And so reviewing those medications and identifying potentially inappropriate medications, I rely heavily upon the AGS-Beers criteria to identify those potentially inappropriate medications and then have a process for safely deprescribing and then monitoring and supporting. So when we're thinking about high-risk medications, we're thinking about those highly anticholinergic medications and others that have increased risk for delirium, cognitive impairment, and Alzheimer's disease and related disorders. And as we all know, hopefully, if not, I'm telling you again, we have to look out for a lot of those over-the-counter high-risk ones, that all those things with PM in it that might have diphenhydramine in it, huge, I can't tell you how many times somebody say, oh, well, I take whatever PM every night for the last 10 years to help me go to sleep. Well, that's a huge problem that we need to be able to address. And then there are cool tools. Here's another cool tool you have access to, this ACB calculator that will help you calculate the anticholinergic burden for a particular patient based on you enter their meds and you see there. That can be helpful because maybe you're thinking like, I'm going to use something for depression and I didn't realize that paroxetine is more anticholinergic. So maybe I could choose something else that's similar, that's not so highly anticholinergic. And then back to our social prescription and an overall brain health plan, right? Brain health plan should be as routine as managing anything else. Patients, they're more likely to engage when the recommendations are personalized and attainable. We can tailor the plan to their unique risk factors, their preferences, etc., and we can guide patients towards evidence-based strategies. So here we are encouraging more walking. We're getting somebody connected through a call club program. We're adjusting their statin medication, and we're getting them connected to specialists to deal with their sensory impairments. And with that, I'll go back to where it's all happening in primary care with Dr. Gaster.
My name is Brock Gaster, and believe it or not, I am a primary care doctor who is also an expert in dementia. And so it's been, I'm still sort of practicing 30% of my time doing just regular old primary care. But 70% of my time now, I direct a program called Cognition Primary Care that actually started with Lisa McGuire when she was at the CDC. That was really to bring the KAER Care Toolkit sort of to life at a large health system, which is what we did. And so I've been like living and breathing the KER Care Toolkit for 7 years now, and so happy to tell you about the A, the E, and the R. And so, I think it really kind of begins with like, what are the tools that you can use to assess cognition in the primary care setting? And I want to start by really sort of making like all of the items that you see on the screen here get confused. People talk about them somewhat interchangeably, talk about them all as screening tools, but it's really, really important to distinguish the brief items on here, which are like the 3-minute tests, like the mini cog, which are screeners, which are really different than tests like MoCA, SLUMS, RUDOS, which are 10 to 15-minute tests that you're never really going to be able to screen somebody in 10 to 15 minutes. Like that's just like too much time to spend for screening. But these are diagnostic tools after somebody has had an abnormal screen, the MoCA, SLUMS, and the RUDOS. And then really, and those are different than the tools that you can use to assess somebody's functional status, like the FAQ and the Law-Brody. And so it really kind of all begins with like this trigger moment. So this is like the A is this like assess trigger moment, where the two main sort of common triggers are either somebody has an abnormal brief screening test. So that's the 3-minute test, like the mini cog. And that is often going to happen at an annual wellness visit. If somebody has an abnormal screening test, they need an evaluation. They need further assessment. But it's really important that we kind of don't just rely on that screening test, because those screening tests are really good. They're important, but their sensitivity for mild cognitive impairment is not it's not good enough to rule out mild cognitive impairment in somebody who has a cognitive concern. So when somebody walks into a clinic visit and says, I'm worried about my memory, just because they have a normal mini cog doesn't sort of mean like, you can completely reassure them that you really do want to think about what are additional questions that you could ask in that situation. Like incredibly common scenario. Somebody walks in and says, I've been worried about my memory. I can tell you that 7 years ago, as a very experienced primary care doctor, I really wasn't sure exactly what I was supposed to do when somebody walked in and said that. And so that's really sort of a really, really important sort of transformative change that we need to make in primary care, so that every primary care setting knows what to do when somebody says, I'm worried about my memory. Because at that point, you need more information, because just a lot of people are worried about their memory. That they don't all have mild cognitive impairment. People are just so freaked out about this. They're so worried about developing Alzheimer's disease that a lot of people who say they're worried about their memory are not cognitively impaired. They are sort of normal. And so it is important at this moment to get a little bit more information, because sometimes you can sort of, by understanding a little bit more what their concern is, you might be able to just reassure them. But by asking more questions at that point, you may be like, oh my goodness, this is actually a very serious concern. No matter what this person's mini cog is, I need to do a cognitive evaluation. And so, it's really, really important to sort of distinguish between these are the changes that are consistent with normal aging. I misplaced my keys, but then I found them in a normal place. Or I went up the stairs. I couldn't remember why I went upstairs, and then I came downstairs, and then I remembered. Or it takes me longer to remember sort of a word or somebody's name, but like later it sort of comes to me. Like those are normal aging things. They're really, really common. They freak people out, but they are not signs of cognitive impairment. And it's really important to distinguish those things from really serious signs. And this is all, taken from a really beautiful sort of actually 10-item handout that the Alzheimer's Association put together called The Warning Signs of Alzheimer's or Dementia, which are the really, really serious things. So anytime you hear one of these 3 things, like huge red flags should go off. This is somebody who needs a cognitive evaluation, again, regardless of what their screening test is. So somebody who is asking the same question 30 minutes later, somebody who is finding it harder to do a complex task that used to be very, very easy for them. Somebody who's becoming disoriented in a place that they should know well. So not getting lost in a new city, but a place that they have been to hundreds of times, that they suddenly stop because they are sort of disoriented and not sure which way to turn. Those are three really worrisome signs. Anytime you hear any of these three things, somebody absolutely needs a cognitive evaluation. So it's not to say that if like people don't have this, but they're worried that you can't still offer a cognitive evaluation. But these are the warning signs that say, absolutely, we need to do an evaluation. So that's the E, the evaluation. So let's talk about what an evaluation in the primary care setting actually looks like. And so you know, the first thing you want to make sure to do is to say, I really want to do this evaluation, but I gotta tell you, I can't do a really good job of doing this evaluation unless we have somebody who spends time with you. So either ideally a family member, but it could just also be a close friend. Really important for that person to come to this follow-up visit where we're going to do this evaluation, because I can tell, like, even the world's best dementia experts really cannot adequately assess somebody's cognition without getting some input from an observer, a family member, or a close friend, to say how that person is navigating through the world. And so the three parts of this evaluation visit are, you're going to complete a cognition checklist that I'm going to show you in a second. Those are the easily addressable factors that you can sort of actually easily fix in primary care. You're going to assess cognition with a diagnostic aid tool. So, people call MoCA a screener, and that's very confusing for primary care, because screening is sort of like different than what we're doing here. Here, we're really sort of we're moving forward on an evaluation after a concerning symptom has arisen. And so that in the primary care world, that's not screening, that's evaluation, that's diagnostic aid testing. Which is such as a MoCA. And then again, it's going to be so important to try to have a family member, close friend at that visit, because in the primary care setting, you're going to try to get some input from that person, and you're going to put these three things together to do your evaluation. And so here's the cognition checklist. And so you can download this from our website, cognitionprimarycare.org. And these are like the three things that we try to embed it in the electronic health record, so that when you're doing this evaluation, you don't have to remember all of these things, but it really comes up as a checklist in your EHR. The lab tests are easy to remember. As Dr. Kaiser talked about, you really want to look at their medication list and ask about over-the-counter medications that are like probably the most common unrecognized cause of cognitive impairment in America. So, diphenhydramine in the Tylenol PM that people think is like, oh, it's great because I heard that I really need to get sleep in order to prevent dementia, but they're actually making their cognition worse. Asking about alcohol intake, and here you're not necessarily talking about alcohol use disorder. You're not talking about somebody who is sort of, has like a substance use problem. You're talking about somebody who has been drinking 3 to 4 drinks their whole life. It's never functionally impacted their life. But now that they're 70 years old and they are sort of being concerned that their memory isn't working as well, telling them that reducing their alcohol intake will make their brain work better is like an incredibly important thing to not miss, but you have to ask about it to find out about it. And then, as Dr. Kaiser talked about, these comorbidities that we really need to ask about and treat in the primary care setting to improve brain function. And so now we're going to talk about, so you've gone through the easily addressable factors in your cognition checklist. So now you're going to do a MoCA test or another diagnostic aid test, and you're going to put that together with input from the family member, and that is your assessment. And so I really do talk about the MoCA a lot, as, is probably the most used test in the United States for assessing cognitive impairment, again, as a diagnostic aid for mild cognitive impairment or dementia. It's been really well validated, and it's better than the mini mental status exam, which is sort of what I learned about in medical school 30 years ago. That is really sort of not at all really what we should be thinking of as like the standard of care. Mini mental status exam is not a great test. The MoCA test is a very good test. And it is challenging to do a MoCA test in an office visit. No question about it. We can do it in primary care. One of the ways that you can do it easier is you can sort of train a medical assistant easily to give a MoCA test, or really, anybody on the care team can learn to administer a MoCA test. The most important thing is that you don't want to sort of just kind of wing it, and I think that is a misunderstanding that happened with the mini mental status exam. People learn the mini mental status exam is like just something that you kind of like wing as part of your physical exam. And that's like not really how you want to be doing the MOCA test. You want to be using scripting that both sort of like has like the exact way that you're asking the patient to do a task, and then actually also using really careful scoring instructions to make sure that you're scoring it correctly. And so this is something that you don't need to be a clinician to learn how to do that, but you do want to have a little bit of training to sort of make sure that you're doing it right. And, and in terms of like a billing tip, like if any technician, which could be a medical assistant or anyone, can actually bill to give a MOCA test, they have to do a MOCA test plus sort of another sort of instrument like the PHQ-9 or the GDS. But if you do two of those, if a medical assistant gives two of those tests, then they can actually bill the 96138 CPT code. All right, so now how are you going to get the input from the family member? You really want to sort of, I actually boil it way down to the three questions that are actually similar to the worrisome signs that I sort of pointed to on the Alzheimer's 10 warning signs. But these are like three questions that you really do want to make sure that you're asking the family member or close friend. And so you can either remember those three questions, put them as a sort of a smart phrase into your electronic health record to remember them, or another sort of tool that you can use to guide you through the interview with the family member is called the 88 questionnaire. And here's just a snapshot of what the top of that form looks like. It's 8 items. And the most important thing is to think of this as not a scored instrument. This is not just like a 1 point, 2 point, 3 point, and sort of that's your answer. I really would encourage using the 88 as a structured way to interview the family member, because if there's a yes to any one of these questions, it's not just sort of a point on the score. It's an opportunity to say, oh, tell me more about that, because that's the way to really sort of get the picture of how is that person navigating through the world. And so you're going to put those two things together. You're going to put the MOCA test together with the family input. And, that is, a diagnosis of mild cognitive impairment. If the MOCA score is low, the observer is saying, yes, they are asking me the same question 30 minutes later, but they are still fully independent with their activities of daily living. That is a diagnosis of mild cognitive impairment that we can and should be making in primary care. That, if we are sort of like hoping that, there's going to be sort of like a magical sort of cognitive neurologist we're going to rely on to make that diagnosis, or a geriatrician who's going to be able to make that diagnosis, we are never going to be able to diagnose the vast number of unrecognized people with mild cognitive impairment. It's got to happen in the primary care setting. Primary care can make this diagnosis, and this is how to do it. To distinguish mild cognitive impairment from dementia, it's more or less similar in that the MOCA score is low. It's often much lower. You also want to be getting that sort of input from the family member that they definitely have changed over the last year or two, such as asking the same question 30 minutes later. And they are starting to lose independence with one or more activities of daily living, which can be things like shopping or driving or managing finances. If somebody is losing independence with one or more of those activities of daily living because of their cognition, that is a diagnosis of dementia that, again, we can be making in the primary care setting. All right. So pitfalls are the most important pitfall is making sure that you're not sort of getting confused about delirium. So delirium is a very, very, very common thing in older people, and it can be sort of this is a transient cognitive impairment that can be brought on by the something so minor as just like a urinary tract infection can cause delirium in older people. And it is so important to not mistake delirium for mild cognitive impairment or dementia, so that you really can't and shouldn't be doing this evaluation during or even soon after any kind of an illness. And it's especially true if somebody is been in the hospital with a severe pneumonia. So if somebody has been in the hospital with a severe pneumonia and say they got very, very delirious as part of that hospitalization, and then they seem to have recovered, it's actually really important to identify that, especially like a severe illness, like a hospitalization for pneumonia, that delirium can actually cause sort of lingering effects for months. And so you really, really want to make sure that you have given somebody a lot of time to recover from an acute illness before you're giving them a MOCA test. It's just, it's not going to be sort of diagnostically accurate. That said, you don't want to ignore the fact that they had that delirium, because delirium is a huge risk factor for cognitive impairment. So somebody who has had an episode of delirium is at much higher risk of being diagnosed for cognitive impairment in the sort of 1 to 2 years after that event. And so a delirium event is really important to sort of like wait till they have fully recovered from it, but don't ignore it. That's somebody who you do want to really strongly consider doing a cognitive evaluation on, but you want to wait sort of plenty of time. And making sure that you are sort of addressing sort of hearing impairment or vision impairment when you're doing testing like this. Just to take a second to talk about the very, very sort of low literacy sort of population, because that is a really big problem. So somebody who has never learned to read is not going to do as well on the MOCA test, and it's not because they have cognitive impairment, but it really is that low literacy is sort of a real kind of barrier to answering some of the questions on the MOCA test. And so that's actually where I would sort of point to using the RUDOS. So the RUDOS was developed in Australia, especially to help with Indigenous people in Australia who have never had any education at all. And so the RUDOS is a really important test to consider instead of the MOCA for somebody who has very, very low education level. All right. And so now sort of, we're going to act, we're going to do something. And so you have put the MOCA test together with the input from the family member. You've sort of reviewed your cognitive checklist, and it may be that everything looks fine, and that should be sort of a relatively sort of common thing that happens in primary care, because if all of the people we evaluate we find impairment on, we're not evaluating enough people. And so you are going to end up at the end of this evaluation visit with good news that, but I can sort of, it really doesn't look like you have cognitive impairment, and that's a wonderful thing to be able to say. If you found any contributing factors in your cognition checklist, like those are like important things to follow up on in the primary care setting. But you also may have made a new diagnosis of mild cognitive impairment or dementia. And that's like a really tricky moment where you really want to be ready to say, I need to sort of, I'm worried about this, and it is potentially a problem. I really do want to see you back in sort of 1 to 2 to 3 weeks so that we can really talk more about this diagnosis and make a plan. You really want to make sure that you are sort of building in like a phrase that like helps you to sort of bridge to that next visit, because I think this is like the hardest thing in primary care, like sort of how do you, at the end of this visit, making sure that you sort of are getting to that good follow-up step. And so, what do you do at that follow-up step? You're going to talk about what the diagnosis means, and then you're going to sort of make that action plan. And so you want to ask permission. It seems a little bit sort of intuitive, but it seems a little sort of silly to ask, is it okay for us to talk about this? Because of course it's okay to talk about it. That's why they're there. But you really, that is like a really sort of polite and respectful way to kind of like frame the conversation that we're going to talk about something serious, and do I have your permission to do that? You want to sort of acknowledge that this is a scary thing to talk about, but really also sort of weave in that there's actually a lot of optimism with a diagnosis of mild cognitive impairment. It's like your life is not over. It's very likely that you're going to have many years of really good quality of life left to live after a diagnosis of mild cognitive impairment. And the key is that you're going to be there with them, sort of like to help sort of guide and make things as good as they're going to be. And you're going to do that in a series of ongoing visits. Let's take a second to talk about blood-based biomarkers, because this has been sort of one of the sort of biggest sort of news items in the field of Alzheimer's research in the past year or two. There's now 2 FDA-approved blood-based biomarkers, and it's really important to identify what these tests can do and what they can't do. they can't tell you whether somebody has cognitive impairment or not. What they can do is they are very good at predicting whether you're going to see evidence of Alzheimer's disease on a PET scan of the brain, which is actually a big deal because a PET scan of the brain is a really big, expensive, and invasive test to do. And so if you can do a blood test that is going to predict what somebody's brain PET is going to show, that's a huge advance that really can be extremely important, especially for triaging people for anti-amyloid therapy that we're going to talk about a lot. But it's really important to identify that the current state of the science is that we really shouldn't be doing blood-based biomarkers before a diagnosis of cognitive impairment has been made, because we're still a little bit not sure like what that means. So somebody who is not cognitively impaired, who has signs of Alzheimer's disease on their brain PET scan, is still a little bit unclear of like, how are we really sort of going to change our practice based on that blood-based biomarker result. And so I really would sort of make the point, blood-based biomarkers are really, really important tests to be aware of, but they really shouldn't be used until after a diagnosis of either MCI or dementia has been made. All right, because now we are on the R. So we're on the last one. And so R is refer, and I think it is sort of complicated to say, this is more than refer to a specialist. This is actually refer to all the important resources that we really can and should be sort of linking people to, especially in the primary care setting. I want to start by talking about these are like the 4 really, really huge red flags that should prompt an earlier referral to a specialist. And calling out visual hallucinations is a really important one. That's a high risk marker for Lewy body disease, which is an important diagnosis to make, which is not easy to make, especially in the primary care setting. But so anybody who you want to remember to ask about visual hallucinations, anybody who has visual hallucinations in the primary care setting together with their cognitive impairment really needs to see a specialist sooner rather than later. So now let's talk about the 2 FDA-approved anti-amyloid monoclonal antibody drugs. So this is lecanemab and donanemab, which are, really sort of important to know about, because in the last 2 years now, we have very solid evidence from randomized controlled trials that both of these drugs can slow the progression of cognitive impairment by 4 to 6 months, which is, it's a huge deal. This didn't exist in the sort of the many years that I have been sort of working in dementia, especially in primary care. But we do now have 2 drugs that are better than placebo at slowing the progression of cognitive impairment. What's really important to know is that these are sort of not at all easy drugs to administer, and they have pretty significant side effects as well. And so, really important to identify that they carry significant risk of brain edema and bleeding. So you're not eligible for either of these drugs if you're on an anticoagulant, like either warfarin or a direct oral anticoagulant. And that they are sort of not easy drugs to administer either. These are infusions that sort of are either once a month or twice a month, and so it takes a lot to sort of administer these drugs. So I really do not see these as sort of treatments given in the primary care setting. These are treatments that are given in the specialty setting, but it's important for primary care to be aware of them, to be able to talk to patients about the possibility if they have Alzheimer's disease. And so these are treatments for Alzheimer's disease. There are lots of people with mild cognitive impairment who do not have Alzheimer's disease who still need lots and lots of good sort of extensive comprehensive care. And so this is not sort of the be all and end all of treatment for mild cognitive impairment, but it's an important thing to be aware of. All right, I want to really sort of, it's a crime that more people don't know about Best Programs for Caregiving, which is a national database that really sort of keeps track of really high quality, well sort of established programs around the country. So Best Programs for Caregiving. One final sort of billing tip is that a really, really important sort of thing that can be done at an annual wellness is talking about advanced care planning. And so people ask me, should somebody with dementia still go in for a Medicare annual wellness visit? And I say absolutely. Like that is such an important way to sort of track in primary care how is somebody sort of functioning in the world. And since you're going to probably spend less of that visit talking about sort of colonoscopies and mammograms, and you're going to sort of you're going to have more time to talk about advanced care planning. And if you spend more than 15 minutes talking about advanced care planning at an annual wellness visit, and you add the CPT code to that visit, you double the revenue that you get for that visit at no extra cost for the patient if it's done at an annual wellness visit. All right. So thank you all so much, the A, the E, and the R, and it's a pleasure to talk to you.
All right. Well, let's hear what you all talked about. I know you were all talking. So group one, let's hear what you have to say.
We had a very engaging discussion on Anita, 52-year-old with new onset hypertension. I guess really quick summary for those who didn't have this case. High blood pressure, hypertension, class 1 obesity. She has early menopause, high cholesterol, family history of dementia. She's a current caregiver for her mother who was recently diagnosed with dementia. As far as lifestyle factors, she doesn't really exercise as much as she wants to, eats fast foods a lot for meals. So those were the risk factors that we identified as the hypertension, the obesity, all these kind of significant medical history of Alzheimer's disease is a big risk factor. Caregiver burden, and this, increased stress. She mentioned she works full time, doesn't have a lot of time to care for herself, has burden caring for her mother. We mentioned maybe a question of social isolation. It might be an issue too, because of her, I don't know, full-time job and full lifestyle, not really leaving room for social interactions. So top priorities are definitely the blood pressure control, hypertension, got to get that under control. Caregiver relief, to just reduce caregiver burden. We jumped a little bit ahead on the last question. Which strategies or approaches would we recommend for that? Refer to perhaps a social worker, a connector with resources, maybe a nutritionist to help with a diet, help her to manage her diet better, decrease those fast food meals, increase exercise. And as far as caregiver support, there's support groups available with the Alzheimer's Association, for example, and other community resources that we could suggest. And in terms of how would you recommend engaging Anita in a conversation about brain health during this visit, we really liked the speaker's suggestion on our approach to the conversation. Ask if it's okay. Is it okay for us to talk about this? Acknowledge her fear. In the case, she mentioned that she does have a fear of her future because of her history of Alzheimer's disease. So acknowledge that, normalize, that's okay, that everyone sort of has this fear, and just take that approach to have that conversation with her.
Thank you so much. Additional things that we thought about Anita.
Apart from what has already been discussed, I think one thing our group talked about was for the third question about how would you start a conversation. Obviously the first permission part that was mentioned, but also, being honest with her that yes, some of these factors about your current lifestyle are risk factors. But the good thing is that they're modifiable, and we can, as a team, show her support that you're not alone in this fight, but we're all kind of there to support you through it, and they're modifiable. And kind of addressing the last question was introducing small lifestyle changes so they don't seem really, daunting tasks initially, but kind of have a gradual increase in trying to help her manage her time in a way that's better for her.
All right. Thank you.
I think I heard somebody say group one was the best. So
Of course
I was
they did.
away with group one. So now let's see. It's on you, group two. Healthy competition here.
Too short.
Good job, group one.
Okay, so Jerome is a 66-year-old presenting for a prescription refill. He's currently taking paroxetine and diphenhydramine as needed for insomnia. He also has a medical history of major depressive disorder with recurrent episodes, but he is stable on his antidepressant, which is paroxetine. I'm going to not read the visit notes right now, but some of the risk factors that we noticed in Jerome's medical history were depression, his history of poor sleep, being 66 years old, so above age 50, and then taking the diphenhydramine, which I can't pronounce this word, is an anticholinergic, and can cause confusion and hallucinations and dementia per the Parkinson's Foundation.
Thank you.
So for the third question, we got, would you recommend a cognitive assessment for Jerome? Why or why not? If so, which cognitive assessment would be the most appropriate and why? So we talked about two assessments, which is MOCA. We already well known that is good assessment for cognitive task, and then they will do at the baseline and they'll ask them revisit to see how their cognitive functioning. He was worried about his memory, so that is kind of good follow up. That is really true or not. And then the another one was Allen cognitive level, that is kind of screening for dementia. So that is not likely as a task like MOCA. That is more likely problem solving in a new situation. So they just talk about the situation and then they have to solve the problem. That means processing the new information so that they know the person really has the memory loss or cognitive problems. So that's what we talked about.
Thank you so much. I think that group did pretty good too.
Oh, yeah.
Pretty good, Dr.
Neck and neck.
Yep.
Head to head.
All right. So group 3. So we're going to talk about Harold.
Okay, so for number 3, talking about cognitive assessments, while I thank everyone for their in detailed use of the MOCA, I pose an option for everyone. I'm an occupational therapist, and while it's I know it's not a screening tool, but that initial test that people often do for assessment, I argue from the other perspective, what happens when someone who administers it improperly or is not trained in interpreting the results mislabels someone, a score kind of stays with someone forever. While a MOCA might be warranted in this opportunity, I would take the opportunity to look at his whole functional status, because a lot of the changes that we've noticed have been participation in daily life activities. So looking at the CELS, which is the Coleman Evaluation of Living Skills, might be something that might in more detail capture his functional deficits, and also asking permission for the MOCA use and its implications for driving. I think that is something that also often goes under the table, and to talk to that concept of trust with your patients if you are administering a score that can have significant implications on their independence and their quality of life, that we just have to be cognizant of how we do that. Thank you.
Thank you.
Okay. Thank you. So the question was, what interventions would you recommend as part of a brain health plan for Harold, and how would you prioritize them? So in no particular order, because of all the features we saw in Harold, we recommended improved nutrition. Fine, we saw he was eating canned foods, and most canned foods, if not all, they are not healthy. So we recommended improved nutrition, increased socialization, and the case study also mentioned that he was bereaved, so we could indulge him in a day program that could help him meet more people, widows club that could help him mix up with people, try to get back his life. And also the case study mentioned that he was always falling and stuff like that. So fall prevention is another very important intervention. Then we could also involve him with balanced exercise and also referrals to grief counseling and so on that could help boost his mental health.
Right. Thank you. Thank you. What great discussions. Dr. Kaiser and Dr. Gaster, I think they listened to you. I think they learned a lot. Is there any things that you gentlemen would like to add to the feedback that you've heard?
Well, I mean, I think with the case we were just mentioning, I would ask, I mean, how concerned are you that he may be suffering from something that's not just a normal age-related? You just yell out high level. I mean, I think I just wanted to make sure, because we had great conversation about sort of the brain health aspects, but I think what we don't want is this person to go undetected. And this is a very concerning constellation of findings. I think getting that functional history is really key. That was great. I think that you raised great concerns about the something like the Montreal cognitive assessment, but I would argue that it is important to use standardized, validated tools and to do that in a shared way with patients. Like you said, noting the potential implications, but that people should be trained to administer and interpret appropriately. And what's great about something like the Montreal is that training is available and there's guidebook to guide you. And then, case one, I really like that this is where we're going way upstream and really thinking about this primary prevention opportunity in somebody who we know has all of these modifiable risk factors and some non-modifiable risk factors. So I think it was great, the energy that you all brought to it. And I think we even have a little time for questions from you.
Now, people have submitted some great questions, and I get the fun job of censoring them. So these are going to be the ones that Lisa finds the most interesting. So the first thing that someone asked was, Dr. Gaster, you mentioned, using the informant or having a family member, friend, or spouse and getting additional information. The question that was asked, though, about that is how can you get that input without making the patient feel like you're doubting what they're saying?
Yeah. So that's a great question. I think that that what I tend to do is that, so ideally you've got the family member there with the patient at this evaluation visit. And so I really want to, while I'm doing my cognitive testing, it's really handy to give the family member something else to do to sort of so that they don't sort of, the person who's getting tested doesn't feel like the family member looking over their shoulder. So, I mean, that's actually a great moment to give somebody the 88 questionnaire. And what I really, try to move towards is having a version of the 88 where it's not just a yes/no questionnaire, but it's tell me more. And so if you can get the family member to kind of start writing down some things about each of those items, then it gives them an opportunity to kind of communicate with you sort of in a less tense way where they're kind of ratting somebody out. I think this is a great moment to I hate the word informant. So, in the research sort of community, the word informant is the term for that sort of family member, close friend. But it's that's such a horrible kind of ratting somebody out, that they're informant. And so really using the word sort of observer or sort of family member, close friend is so much better. And giving them a chance to kind of like write some stuff down for you rather than having to say it out loud is really good.
Okay, so I have a question I'm going to ask Dr. Kaiser. So this one is, he talked quite a bit about risk reduction and talked about some of the different evidence from the latest scientific results. And this person pointed out that they rarely see stress addressed as a risk factor. And they're concerned about that given the evidence of stress hormones with allopathic load upon body systems. Why isn't it included in the list of risk factors?
Right. And we talked about that in the context of the cases of that, the caregiver strain and the stress of being a caregiver and all the work-related stress. I do hope to see that come in future guideline releases. I think that I think it's just a matter of codifying the evidence around that. But in terms of in practice, would we think of chronic unmanaged stress as a risk factor, modifiable risk factor? 100%. 100%.
Great. Thank you very much. So, Dr. Gaster, so we talked a little bit about various screening, assessment, evaluation type of tools today. Are there tools out there that can be self-administered by the patient or family member prior to the clinic visit?
Yeah. And so, so that is there's so much interest in trying to figure out how can we do even a better job of screening that is hard to do screening in an office visit, and could something be done at home before somebody comes in? And yes, I mean, I think that's definitely an area of sort of active research, and I think has a lot of potential to it. And I think what's really, really important is to differentiate between a screening test that just like raises a flag as opposed to a diagnostic test. And so, I really don't think that we are anywhere near having unsupervised diagnostic testing. I mean, the observation that was made earlier was really good, that you can sort of really like screw up the MOCA. You can do it wrong, and you can sort of like mislabel somebody. And, it's like the answer is not to sort of not test somebody, but really to make sure that you're testing them well. And so I think unsupervised testing is a huge potential sort of harm situation. And so I don't think we are sort of there for diagnostic testing, but I think the idea that somebody could do some kind of a screening test before coming in for an annual wellness visit has a lot of potential.
Thank you. So once again, this is an amazing session. And before we wrap up, I just want to make sure you're aware of the great amount of resources that are available. So please check them out. Remember, you got that QR code on the back of the card at your table. Make sure you take it. Plus a nice pen. Make sure you take that too.
Yeah, I think we still have some closing
I
thoughts. There are more resources from, again, you guys can get that QR code, check out the website after. Okay, take-home messages. It's never too early or too late to think about brain health and dementia prevention. Did we all get that? Are we feeling that? Never too early, never too late. Okay, modifiable risk factors offer real opportunities to reduce dementia risk. Reliable tools can help spot early cognitive changes, but should always be interpreted in context. Informant input helps complete the picture and should not be overlooked. And finally, open, early conversations about brain health are essential for effective dementia prevention, identification, and management across the life course. Okay, thank you all for being such an engaged, attentive group, and we'll hang around for any additional questions.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, Peerview Institute for Medical Education. This activity is developed with our educational partner, Bright Focus Foundation. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/UAH860.